Hello, my name is Lawrence. I went to the hospital a few months ago after experiencing serious stomach pain. At first, I was noticing some irregularities when I went to the bathroom. I didn't think about it too much, but then I noticed that the whites of my eyes looked a bit yellow. Then I started to feel stomach aches and had a light fever. I also noticed really light colored bowel movements and my urine was much darker than normal. The yellow in my eyes concerned me the most, so I called my doctor right away. After the doctor assessed all my symptoms, she said I might have gallbladder issues and suggested that I avoid dairy, eggs, and sugar. I knew that would be difficult because those ingredients are in a lot of my favorite foods. After some additional tests, I ended up in the hospital having my gallbladder removed. I thought that would fix everything, but after the surgery, I had a blood infection, so I had to stay in the hospital. I got really sick, and the doctors told me I had a hard time staying awake. My blood pressure wasn't stable, so the doctors brought in a code team to keep me alive. I was moved from the surgical unit to ICU and stayed there until the doctors figured things out and made sure I was healthy enough to go home. It's been tough, but I'm extremely grateful for all the help and care I received at the hospital, especially for the surgical ward recovery team who saved my life.
My name is Alan and I am a medical laboratory assistant. I collected Lawrence's blood when he was a patient at the hospital. MLAs are trained in drawing blood samples, so the medical laboratory technologists can test those samples in a lab. Patient identification is a very important part of my job. We follow specific guidelines every time we collect a sample, no matter how often, whether it's once a week or twice a day. We have to be very careful when we collect blood. The first thing we have to do is make sure the requisition matches the patient. In some hospitals, we use a rover. This is a portable system that we use to scan the patient's hospital band during identification. This helps us generate lab labels with test orders. We put those labels on the tubes after collection. When MLAs collect blood, we need to be calm, empathetic, and efficient. We also have to apply our lab expertise as we collect specimens while paying attention to other conditions that might affect the lab results. For example, lab tests can be influenced by intravenous lines, surgical procedures, or special storage requirements, such as keeping the tube on ice. We also need to consider factors that determine our collection technique. For example, we need to consider the age of the patient and whether they have difficult veins. If a patient has difficult veins, we might decide to collect a sample from the hand or foot which requires physician authorization. Of course, we are also responsible for making sure our practice is ethical. Primarily, this means that the patient must consent to the procedure. Consent is implied when they extend their arm after identification. Our job involves more than just collecting blood samples. We also have to be very detailed and precise in our documentation, transportation, and sample preparation. This helps us make sure the lab results accurately reflect the patient's condition. Having these responsibilities means we are the pre-analytical experts on specimen collection, processing, and transportation. At one point in Lawrence's care, we were asked to draw 2 sets of blood culture bottles. The first set was from the left arm and the second set was from the right arm. We sent the specimens to the lab immediately, where it was confirmed that Lawrence had a bacterial infection in his blood. Collecting blood from a very sick patient is one of the biggest challenges for an MLA. In these cases, the tests are ordered stat, so we have to act quickly. This can be very difficult when there are lots of people in the room taking care of the patient, talking, doing x-rays, and doing other activities that can create obstacles. Sometimes people even try to keep us away from the bedside, so we have to be vocal and assertive to get near the patient. The process is a bit easier when there's a doctor in charge of the situation. In those cases, I know exactly who to approach to explain why I'm there. The doctor will look at what needs to be done and then tell me to wait until there is enough space in the room for me to work.
My name is Miles. I am a nurse who works in the post-operative area. When a patient returns from the operating room, the nurse conducts the initial assessment or post-op care and makes sure the patient is stable. This includes taking vital signs and conducting a head-to-toe assessment every 15 minutes for the first hour, every 30 minutes for the next 2 hours, and every hour for the next 4 hours. When we took care of Lawrence, our findings strongly suggested that he had septicemia, so we called the doctor right away to get the blood work started. When we work with someone who is extremely sick, we often need more supplies such as IVs and medications, and more tests need to be ordered. It can be very difficult to manage our roles as we still have to look after other patients as well. In these situations, working as a team really helps. Lawrence was in extreme distress and the course of action was to call for help. We called a code 66, which is rapid medical intervention. During this time, Lawrence coded and needed resuscitation. We called a code blue on the unit. The staff nurses initially started CPR, which includes airway support or ambu bagging. The code team then takes over the resuscitation with the staff nurses helping as needed. The nurses also provide as much background information as possible as we continue our work. The code team will place appropriate IV lines and chart medication delivery. This includes charting what medications were given when they were given, including route by whom, and the effectiveness of the medication as measured by the outcome. The nurses will also chart duration of the code and other timelines, who was involved in the code and the outcome. In this case, the outcome was to transfer Lawrence to ICU. In the ICU, the nurses closely assess all the patient's body systems. When Lawrence experienced a cardiac arrest, we needed to conduct a systems assessment every hour, including full cardiac monitoring. Other nurses and myself set up all IV lines and assisted with central line placement. One of the other nurses also inserted a urinary catheter and assessed the monitoring devices, which included blood pressure, oxygen saturation, arterial blood lines, and a ventilator. As always, we communicated with the healthcare team to report both subtle and significant changes. The nurse's chart is a major part of this complicated process. We use this chart to take note of all invasive procedures and assist with insertion as necessary. As the ICU nurses deliver medication through the IV central line and other routes, they also collaborate with the medical team to discuss medication parameters and algorithms and make sure they are delivered and charted accordingly. The nurse may also draw required blood tests and collaborate with the MRT for any portable chest X-ray. Given our close contact with patients, the nurses have to communicate with the patient's family and offer support. This typically involves answering any questions the family might have and keeping them informed about all procedures and medication. When necessary, we also direct questions to other members of the medical team, since they have special expertise that allows them to help family members fully understand what is happening to their loved one. In Lawrence's case, I spent a lot of time with his partner, answering all their questions.
My name is Frances, and I'm a medical radiologic technologist, or MRT. When a patient is transferred to ICU after a code, they usually require a chest X-ray. This is done to assess the heart and lungs and check any lines or tubes. We bring our mobile X-ray machine into the ICU and locate the patient. Our equipment takes up a lot of space, so we need to make sure the area is clear of large objects like tables, IV poles, dialysis machines, and other potential obstacles. We then talk to the nurse so we can identify the patient and make sure our timing is appropriate. Most diagnostic chest X-rays are done while the patient is standing or sitting up straight. We can even perform X-rays on unconscious intubated patients as long as we can position them sitting up. With the patient in this position, gravity will move fluid downward, allowing us to get a proper assessment of specific heart and lung pathologies. The X-ray machine is positioned first, so the patient is not disturbed until we are ready to take the images. With the help of the nurse, aide, or other healthcare staff, we place the head of the bed into the upright position. The patient is leaned forward so we can place our image detector behind them, and then we gently lean the patient back onto the device. Then, we adjust the size of the radiation field to include all the required anatomy on the image. A lead marker is placed to indicate the anatomical side of the patient. Once the X-ray is ready, we have everyone move about 10 feet away from the patient and X-ray machine. Just before we take the X-ray, we say X-ray out loud. While watching the patient, we take the image on inspiration. This allows us to capture the image when the lungs are inflated. As soon as the image is taken, we remove the detector and help the nurse get the patient into a comfortable position. The image can be viewed immediately by the ICU doctor who receives the radiologist report.
My name is Sandra, and I am a medical doctor. As the senior surgical resident, patients are my responsibility when I'm on surgical service. I had a bad feeling about Lawrence's condition immediately post-op. I didn't mention this to the nurse because I couldn't provide conclusive evidence of any specific issue. In retrospect, I should have mentioned this to the nurse and asked for Lawrence to be monitored more closely. When I got the call that he was getting sicker on the unit, I scrubbed out of the operating room to go to the ward to do a full assessment. Lawrence had a fever, lowish blood pressure, and tachycardia, so we started septic work and gave him fluids. Then the situation changed very quickly. There was only one nurse, and it was hard to get all of the orders done as quickly as we needed. I felt bad for asking her to do so much herself. Fortunately, she was able to call in a respiratory therapist when we saw that the oxygen requirements were increasing. This helped us get the arterial blood gas done. Now that I can look back on the situation, I should have called the Code 66 team sooner, just to have more people available. I have been trained to call for help early, but it's still difficult to take this sort of initiative. Everyone in the hospital is just as busy as you are, and you don't want to look like you can't handle it. Once we lost Lawrence's pulse, we called in the Code Blue team, and he was resuscitated almost immediately. I was relieved that the team was able to do such a great job. I also learned a lot from the debrief, especially about calling early when I think that help is needed. Lawrence didn't need to stay in ICU very long, so I feel very fortunate that everything worked out.
As you can see, I interacted with many different health professions along my journey. It is great to see how these professions work together to ensure I get the best care possible.